Welcome to the deep dive, where we sift through the sources to give you the essential knowledge fast. Today, we're tackling a really big one, diabetes mellitus. And, the name itself has this fascinating history. Diabetes, Greek for to pass through like a siphon. It's a direct reference to that excessive thirst and urination. And mellitus, that means honey sweet, because centuries back, they actually tasted urine to check for sugar. Kind of amazing how far we've come.
It really is a stark contrast, like you said.
Okay, let's unpack this journey into diabetes mellitus. So fundamentally, DM is a group of metabolic disorders. The main feature, chronically high blood sugar, hyperglycemia.
Yeah, and that stems from problems with insulin, either making it, using it, or, both.
Exactly. So our mission today is to break down these complexities. We'll cover the different types, how it's diagnosed, and the management strategies. Basically a shortcut to getting really well informed on this critical topic.
And what's striking, going back to the history, is how those early observations, like the urination and the sweet taste, directly led to the name. It's quite different from our very detailed understanding now of how the disease actually works inside the body.
Absolutely. It underscores the progress. And thinking globally, the scale is just immense.
Huge.
You look at a place like Egypt, for example, they've got really high rates, something like 21% of adults with type 2 and 12.2% of young people with type 1.
And that's just one example. It's a massive global health challenge.
It really is. And as you said, it all comes back to that core issue, chronic high blood sugar, because the body can't manage glucose properly. So let's start decoding the types, because it's definitely more complex than just type 1 and type 2. First up, type 1 diabetes mellitus, T1DM.
Right.
This one's autoimmune. Basically, your own immune system gets confused and attacks the beta cells in the pancreas.
The insulin factories.
Exactly. So you end up with an absolute lack of insulin. It often hits pretty suddenly, usually in childhood, and sometimes the first sign is diabetic ketoacidosis, DKA, which is serious.
And there are variations even within type 1, right? Like LADA.
Yeah, good point. There's the standard autoimmune type 1A and then LADA, latent autoimmune diabetes in adults. That one's tricky because it develops later, so it can sometimes be mistaken for type 2 initially. And there's also a rare idiopathic type 1B.
That distinction, especially with LADA, is so important clinically. Getting it wrong means delaying the right treatment, which is often insulin. Knowing these nuances helps ensure patients get the proper care pathway from the start.
Definitely. Okay, then there's type 2 diabetes mellitus, T2DM. This is the one we see most often, by far.
Much more common, yes.
And unlike type 1, type 2 has a stronger genetic link, but it's also heavily tied to lifestyle things like obesity, not being active enough.
Right, and the mechanism is different too.
Yeah, it's usually a double whammy. First, your cells become resistant to insulin. Like, the key doesn't work well in the lock anymore.
Insulin resistance, yeah.
And second, over time, the pancreas just can't keep up producing enough insulin to overcome that resistance. So you get this relative insulin efficiency.
And the really challenging part for clinicians and for patients is that T2DM can be silent for years, undiagnosed.
Exactly. Sometimes it only gets picked up when complications have already started to develop, which is why screening becomes so crucial. And it doesn't stop there. There are other forms we need to be aware of. MODY, for instance, maturity onset diabetes of the young.
That's the genetic one, right? Not autoimmune, not linked to obesity typically.
Precisely. Shows up early, usually before 25. Then there's gestational diabetes, GDM, develops during pregnancy. Important because it affects both the mother and the baby's health, short and long term.
Increases the mother's risk of type 2 later on, for example.
Right. And then there are rarer causes problems with the pancreas itself. Certain hormone disorders like Cushing's, even some medications like corticosteroids can trigger it. So here's where it gets really interesting. Nailing down the key differences between type 1 and type 2. For anyone in healthcare, really understanding this is fundamental. Expert, what are the core distinctions you focus on?
Well, the absolute core is the cause of the high blood sugar.
Yeah.
Type 1, as you said, autoimmune destruction of beta cells. Result, no insulin production or very, very little. It's an absolute deficiency.
Okay.
Type 2, on the other hand, starts primarily with insulin resistance. The body cells don't respond well to insulin. Then, gradually, the pancreas loses its ability to pump out enough extra insulin to compensate. So it becomes a relative deficiency, at least initially.
And the link with obesity?
Generally, obesity is common in type 2, often a driving factor. In type 1, it's typically absent at diagnosis, though obviously people with type 1 can be overweight too. But it's not the underlying cause in the same way.
Makes sense. How about the onset? How they first appear?
Big difference there too. Type 1 often comes on quite quite suddenly, acutely, often in kids or teens, sometimes presenting with that DKA we mentioned.
Right, dramatic.
Yeah. Type 2 is usually much more gradual, insidious, often diagnosed in people over 40, and many patients have no symptoms for years. They might find out during a routine checkup, or unfortunately, when a complication like vision problems or numbness starts.
That asymptomatic period is so concerning. And what about measuring insulin itself, or a proxy for it?
We look at C-peptide. It's released along with insulin. In type 1, because there's little to no insulin being made, C-peptide levels are very low or undetectable.
Okay.
In early type 2, C-peptide might actually be high as the pancreas is working overtime trying to overcome the resistance. But later on, as the beta cells get exhausted, those levels drop too.
Got it. And the risk of DKA?
Much higher in type 1, it's a defining feature almost. Generally low in type 2, although it's not impossible, particularly in certain populations or under extreme stress.
And this all leads to very different treatment approaches, fundamentally.
Absolutely. Type 1 always requires insulin, right from the start. There's no other option because the body isn't making it. Type 2 management usually begins with lifestyle changes, diet, exercise, weight loss, and often oral medications to improve sensitivity or boost insulin secretion. Insulin might come later if needed, but it's not always the first step.
Understanding these distinctions is just so foundational for getting the diagnosis right and ensuring people get the care they actually need for better long-term health.
Couldn't agree more. It sets the stage for everything that follows.
Which leads us perfectly into diagnosis and screening. This is really our clinical roadmap for catching diabetes early. So the big question, who needs screening?
Yeah, the guidelines are pretty clear now.
Generally, all adults aged 35 and older should be screened routinely. But age isn't the only factor. If you're taking meds that can increase risk, like some statins, or if you're planning pregnancy and have risk factors for type 2, screening is key.
Right.
And for people under 35, screening is recommended if you're overweight or obese and have at least one other risk factor.
And that list of risk factors is quite broad, isn't it?
It is. Things like having a close relative with diabetes, being from a high-risk ethnic group, not being physically active, having a history of heart disease, conditions like PCOS, high blood pressure, abnormal cholesterol levels, even signs like acanthosis nigricans, that dark skin often seen in folds.
Also specific situations like HIV or cystic fibrosis where screening starts even younger, or post-transplant. It's quite comprehensive.
Basically, if you tick several of those boxes, even if you're young, it's worth checking.
And the reason for all this screening, the why, is really powerful. We have solid evidence showing that finding diabetes early and starting treatment reduces the risk of major complications like heart attacks and even mortality.
That's huge.
And even finding prediabetes is incredibly valuable. Lifestyle changes at that stage can dramatically lower the chance of progressing to full-blown type 2 diabetes and improve cardiovascular health overall. It's a genuine opportunity for prevention.
So how do we actually test for it? What are the tools in the toolkit?
Several options.
A simple one is a random blood glucose test. If it's 200 mg/dL or higher, and you have those classic symptoms, thirst, urination, weight loss, that's a strong indicator. If you don't have symptoms, you generally need 2 abnormal results from any combination of tests.
Right. Confirmation is key in asymptomatic cases.
Common tests include the fasting plasma glucose, or FPG. That's after at least 8 hours without eating. Pretty standard, inexpensive.
Then there's the OGTT, the oral glucose tolerance test.
Right, the one where you drink the sugary liquid. It's considered the most sensitive test, especially for picking up impaired glucose tolerance, but it's less convenient, often used in pregnancy for gestational diabetes screening.
The gold standard in some ways, but definitely more involved.
And finally, the HbA1c, or hemoglobin A1c. This gives you an average blood sugar level over the past, 2-3 months?
Yeah, roughly 8-12 weeks, reflecting the lifespan of red blood cells. Very convenient. No fasting needed, usually.
But it's crucial to remember, as you alluded to, that certain things can affect the A1C result, right? Conditions affecting red blood cells, for instance.
Exactly. Things that shorten red blood cell life can falsely lower the A1C. Things that prolong it can falsely raise it. If the A1C doesn't seem to match up with fingerstick readings, for example, that needs investigation.
Okay, so interpreting these tests, what are the numbers we're looking for?
Knowing the cutoffs is critical. For fasting plasma glucose, 126 milli-GDL or higher on 2 occasions generally means diabetes. 100 to 125 is prediabetes. Below 100 is normal.
Got it. And the OGTT?
For the 2-hour value after the glucose load, 200 milli-GDL or higher is diabetes. 140 to 199 is prediabetes or impaired glucose tolerance. Below 140 is normal.
And the A1C.
An HbA1c of 6.5% or higher indicates diabetes. The prediabetes range is 5.7% to 6.4%. Below 5.7% is considered normal.
So let's talk more about prediabetes, because it's not just this waiting room for diabetes, right? It's a crucial intervention point.
Absolutely critical. It means blood sugar is elevated, but not quite at the diabetes threshold yet.
And the risk is real. You mentioned a 5–10% chance per year of progressing to type 2.
That's right. And importantly, prediabetes itself carries an increased risk of cardiovascular disease even before full diabetes develops.
But the good news, the really empowering part, is that intervention works. Lifestyle changes, like aiming for about 7% weight loss and getting 150 minutes of moderate activity a week, that can cut the risk of progression by almost 60%.
It's incredibly effective. The Diabetes Prevention Program studies showed that clearly. And medication, like metformin, can also reduce risk by about 31%, especially in certain groups like younger, heavier individuals or women with a history of GDM.
So prediabetes is a serious flag, but also a real opportunity to change trajectory.
It really raises a question for you, the listener. Knowing these guidelines and how tests work, how can this empower you or those you care for to be proactive about screening and early detection? Especially understanding that test results can sometimes need careful interpretation.
That leads us right into management. Once a diagnosis is made, it's about mastering the approach, which has to be personalized and look at the whole picture.
Absolutely. One size definitely does not fit all.
For type 1, as we said, insulin is essential, always. For type 2, it's a broader spectrum. Could be lifestyle alone initially. Oral meds, injectables like GLP-1 agonists, maybe insulin, or combinations.
And the choice depends heavily on the individual, their age, other health issues, life expectancy, risk of low blood sugar, even their preferences and ability to stick to a plan.
And it's so much more than just blood sugar numbers. It's multifactorial, right? We have to manage blood pressure, cholesterol, weight, protect the kidneys.
Stop smoking, absolutely critical for cardiovascular risk.
Right. The goal is preventing those long-term complications, especially heart and kidney disease. And newer medications are increasingly chosen for their benefits in those areas too.
And underpinning all of this, the foundation has to be lifestyle. And that starts with education. Good, structured education for the person with diabetes and their family, right from diagnosis, reinforced regularly. Knowledge is power here.
Couldn't agree more. So let's dig into those lifestyle pillars. Nutrition first. Consistency seems key. Eating regular meals, maybe every 4 to 5 hours.
Yeah, helps stabilize blood sugar. Avoiding really late-night eating can also help manage morning glucose levels for some people. Things like intermittent fasting need to be individualized and discussed carefully with a healthcare provider.
And the plate method is a great practical tool, isn't it? Simple visual.
Very useful. Half the plate non-starchy veggies, think broccoli, peppers, spinach. Quarter plate lean protein chicken, fish, beans. And the last quarter complex carbs, brown rice, quinoa, whole wheat pasta, fruit.
Speaking of fruit, any guidance there? People get confused about sugar in fruit.
Good question. Focus on higher fiber options like berries, apples, pears. Be mindful of portion sizes for sweeter fruits like bananas or grapes, and things like dried fruit, canned fruit and syrup, or fruit juice should generally be limited or avoided due to concentrated sugar.
Okay, next pillar. Physical activity. What are the main goals here?
Oh, multiple benefits. Better blood sugar control exercise can lower HbA1c. It increases insulin sensitivity, sometimes immediately after a session, reduces cardiovascular risk, helps with weight management, prevents complications, improves mood and quality of life. The list goes on.
So what's the prescription?
Reduce sedentary time, break up long periods of sitting. Aim for at least 150 minutes a week of moderate aerobic activity like brisk walking, cycling, swimming, or 75 minutes of vigorous activity, jogging, faster cycling, rowing.
And resistance training.
Crucial. At least 2-3 sessions per week. Building muscle helps the body use glucose more effectively, directly impacting HbA1c.
Any quick tips for people starting out or managing glucose around exercise?
Definitely monitor glucose before, during, and after exercise, especially if on insulin or meds that can cause lows. Yeah. Start slow and gradually increase intensity. Timing can help. A walk after meals can blunt post-meal glucose spikes.
Great advice. Moving on to weight management, especially relevant for type 2.
A cornerstone. Even modest weight loss, 5–10% of body weight, brings significant benefits for glucose, blood pressure, and lipids.
And there's even talk of remission.
Yes, particularly with more significant weight loss, like 10–15% or more, especially if achieved early in the course of type 2 diabetes. Studies like the DIRECT trial have shown this is possible for some through intensive lifestyle programs or bariatric surgery.
That's incredibly motivating, and when medications are part of the plan.
The choice often considers weight effects. We prioritize agents that promote weight loss or are weight neutral, like GLP-1 receptor agonists or SGLT2 inhibitors, and try to avoid those that cause weight gain, like sulfonylureas or some insulins if possible.
Okay, what about sleep? You mentioned it earlier.
Increasingly recognized as important. Poor sleep, less than 6 hours or consistently more than 9, is linked to increased T2DM risk, worse insulin resistance, and affects appetite hormones.
So prioritize good sleep hygiene, 7-8 hours ideally, and screen for things like sleep apnea.
Exactly. Treating underlying sleep issues can actually help diabetes management.
And quickly, other factors. Smoking cessation, huge for heart health. Alcohol in moderation, being mindful of hypoglycemia risk if on certain meds. And importantly, mental health.
Yes, addressing diabetes, distress, burnout, depression, anxiety is vital. Managing diabetes is demanding, and mental well-being is intrinsically linked to successful self-management.
This whole lifestyle piece is not just eat less, move more. It's a really comprehensive, powerful set of interventions.
It truly is, often the first line and always essential. Understanding these specifics helps us, and helps you, the listener, empower individuals to really take charge.
Which emphasizes that this isn't a static condition. Management requires constant monitoring and adaptation. It's definitely not set it and forget it.
Precisely. Which brings us to monitoring.
Let's talk glycemic targets. They need to be individualized, right?
Absolutely. The right target depends on so many things. Risk of hypoglycemia, how long they've had diabetes, other health conditions, age, life expectancy, even patient preference.
So while less than 7.0% HbA1c is a common goal for many non-pregnant adults, it might be tighter for younger, healthier people or looser for older adults with multiple comorbidities or a history of severe lows.
Exactly. And assessing hypoglycemia risk at every single visit is critical. If someone's having significant lows, we might need to adjust meds or relax their targets. Glucagon should be prescribed for those at high risk.
How often should HbA1c be checked?
If targets are being met and treatment is stable, every 6 months is often fine. But if targets aren't met, if treatment is changing, if someone's on intensive insulin therapy or experiencing lots of highs or lows, then every 3 months is more appropriate.
Okay. What about that common issue? Early morning high blood sugar. People talk about dawn phenomenon and Somogy effect.
Right. The dawn phenomenon is real. It's that natural rise in hormones like growth hormone in the early morning hours that increases insulin needs and can push glucose up.
And Somogy.
The Somogy effect is the idea that undetected low blood sugar overnight triggers a counter-regulatory hormone surge, causing high morning sugar. It's widely taught, but honestly, there's very little evidence to support it as a common cause. More often, morning highs are due to waning insulin effect overnight, insufficient basal insulin, or just the dawn phenomenon itself.
So don't just assume nighttime lows are the cause.
Correct. It's better to actually check overnight or use CGM data if morning highs are a persistent problem.
Which leads to home glucose monitoring. We have the traditional finger sticks, SMBG, and now CGM.
Both have their roles. SMBG is still important for people on insulin to guide doses, check for lows, see effects of food and activity.
And CGM, continuous glucose monitoring.
CGM has been a game changer. It provides so much more data trends, time spent in target range, alerts for highs and lows. It demonstrably improves overall glucose control and reduces hypoglycemia.
Who's it recommended for?
Strongly recommended early on for everyone with type 1, often integrated with insulin pumps. It's advised for anyone on multiple daily insulin injections or insulin pump therapy, regardless of type. And it's increasingly considered for people with type 2 on basal insulin or even just oral meds if they're not meeting A1C targets or having issues with lows.
And the goal with CGM data is often time and range.
Yes, aiming for 70% of readings within the target range, typically 70 and 180 milli-GDL, with minimal time spent below range, 4%, or significantly above range.
Beyond daily glucose, what about routine follow-up? What needs checking regularly?
It's a checklist. Every visit, blood pressure, weight BMI, review lifestyle, check feet if high risk, HbA1c every 3-6 months, annually, kidney function tests, urine albumin, creatinine TFR, liver function test, liver profile, a comprehensive foot exam, and a dilated eye exam for retinopathy screening.
Anything else?
For people on metformin, Checking vitamin B12 periodically, maybe every couple of years, is recommended as metformin can interfere with absorption. And screening for depression periodically is important too.
And if the diagnosis itself is still a bit unclear, say distinguishing type 1 from type 2 in an adult.
That's where additional tests like C-peptide levels and specific islet autoantibodies like anti-GAD can be really helpful. And of course, if things are complex or not responding as expected, referral to an endocrinologist or diabetes specialist is always a good idea.
It's clear that managing diabetes effectively requires this ongoing, detailed monitoring and willingness to adapt the plan.
Absolutely. Which brings us back to you, the listener. How can incorporating these detailed monitoring strategies, whether using SMBG or CGM, and understanding routine follow-up needs, enhance your approach to managing diabetes, ensuring care remains truly personalized and effective over time?
So this deep dive has really highlighted just how multifaceted diabetes mellitus is. From the different ways it can present, rooted in distinct underlying causes, to the incredibly detailed and dynamic approach needed for effective management, balancing lifestyle, medication, diagnostics, and constant monitoring.
The emphasis truly has to be on that personalized, holistic strategy.
Absolutely. It's about treating the whole person, not just the blood sugar numbers. So as we wrap up, here's something to think about. Considering how much our understanding of diabetes continues to evolve and how intensely personal the management needs to be, what do you see as the next big challenge, or perhaps the next big opportunity, in truly empowering people not just to cope with diabetes, but to genuinely thrive despite it?